Good afternoon. Welcome back to the afternoon session. Our first speaker this afternoon is Dr. Balamugesh. He's a professor, Department of Pulmonary Medicine, Christian Medical College. Bala and I go way back. We've known each other for 30 years, 25 years. So Dr. Bala is a professor of pulmonary medicine. He is awarded the Fellow of Indian Chest Society in 2015. He is also a recipient of the KJR Murthy Oration Award from the Indian Chest Society in the year 2020, the ICMR Research Award for recognition for his scientific contributions in biomedical research in 2006. He is a member of the ACCP and also a life member of the Indian Chest Society. He is an eminent speaker. He would be speaking about progressive pulmonary fibrosis. Over to you, Dr. Bala.
Thank you, Dr. Uma. So, as Dr. Uma told, she was my senior when I did my MD, and then she was my senior when I did my DM in pulmonary medicine in Chandigarh. And as she alluded, 20 years back, we didn't have so many entities of ILD. It was CFA or IPF, that's the maximum we know. Then slowly this FF started increasing. It became CPFE, PPFE, then IPAF, then one more terminology has come is PPF. So we'll try to learn what this PPF means. So this is a lady, 53-year-old lady who had polyarthritis. ANA was 2+, and this was the CT scan a couple of years back. She was diagnosed to have IPAF with fibrotic NSIP and started on immunosuppressive agent. Over the years, her joint symptoms have largely subsided, but she developed progressive breathlessness, and you can see that the lung changes have definitely progressed with more fibrosis as evidenced by traction bronchiectasis. So this is the entity which we are going to discuss about. So we'll discuss about the terminology, how to define progression, the spectrum of PPF, and the treatment modalities. Why another terminologies? We already have so many entities in ILD. We need another terminology called PPF because those who have PPF phenotype, the prognosis is largely different. You can see the survival in those with PPF is much worse as compared to the non-PPF phenotype. Not only that, we have treatment implications. The inbuilt trial published in 2019 showed that nintedanib reduces the rate of fall in FVC in those with progressive fibrosing interstitial lung disease. So there is prognostic implication as well as there is treatment implications in this phenotype. And this beneficial effects of nintedanib is effective across various spectrum of diseases which result in progressive fibrosis. We need to understand the terminology fibrotic ILD. So fibrotic ILD is not synonymous with progressive pulmonary fibrosis. Fibrotic ILD is just based on CT scan or histopathological features. If there is honeycombing, traction bronchiectasis, and reticulation, you can call it as a fibrotic ILD. So what we are considering is progression in the fibrosis. There are various terminologies previously used. The current accepted terminology we should stick to is PPF, progressive pulmonary fibrosis. Among PPF also, we should remember that is it PPF treatment naive or PPF which occurs despite management? If it is completely treatment naive at presentation, we need to know because the underlying etiology may be something different, and if you tackle that inciting agent, then we will be able to prevent the progression from happening. So this differentiation may be important. We need to consider whether progression is happening despite treatment or not. A free-for-all prescription of antifibrotic therapy for all fibrotic ILD should be discouraged. I remember my aunt last year, about this time, she was admitted in another hospital in another city with respiratory failure, and it was diagnosed to have ILD, and in the ICU she was prescribed antifibrotics along with a concoction of other agents with a small dose of steroids. And a proper attempt to correctly label that my aunt's disease was not made, and fortunately she was able to be brought over here and we correctly diagnosed to have organizing pneumonia pattern of ILD due to myositis. So we should discourage free-for-all prescription of antifibrotic without finding out what the actual etiology is, because premature use of antifibrotic monotherapy results in loss of benefits of immunomodulation, because immunomodulation is the only thing which we can consider to improve the lung function. Antifibrotics, what we can do is reduce the progression of fibrosis. So we need to remember that. And approximately 18 to 32% of known IPF ILDs progress despite initial treatment. So only a minority progress if you correctly treat them, identify them, and institute treatment. So in those patients, yes, there is a role for considering antifibrotics. So how to define progression? There is no one-size-fits-all definition to define PPF. You have to satisfy two of the three things: symptomatic progression, pulmonary function testing deterioration, and radiological progression. So, okay, so if you have mobiles, can you please take your mobiles? Some activity is good to keep ourselves awake. What is the PFT criteria for defining progressive pulmonary fibrosis? You can go to the website slido.com and put the code in the number, or you can scan the QR code. What is the PFT criteria for defining progressive pulmonary fibrosis? So majority of you have told it is absolute decrease in FVC by 10%. We will see what is correct one. We need to remember the difference between absolute versus relative decline. Okay, so I have given an example. If the initial FVC is 3.4 liters, which is 85% of predicted value for that patient, and current FVC is 3.2 liters, 80%. So how do you calculate the absolute FVC decline? It is 85% minus 80%, which is 5%. But if you need to calculate the relative FVC decline, we need to find the difference between these two and then divide it from the initial FVC and multiply it by 100. So it is 5.9%. So absolute decline versus relative decline is different, and that is very important to find out what criteria we are using. So this is one of the patients which was discussed in our MDT couple of days back. FVC, previous FVC 2.57, current is 2.35, but the percentage of predicted has actually increased. So this was alluded to by Dr. Kavita, and this is because there is difference in the predicted value for that patient. So we have to carefully look at these values when we interpret the fall in the lung function values. In the inbuilt trial, progression was defined as within 24 months before screening, that is over 2 years, a relative FVC decline of at least 10%, or a relative FVC decline 5 to 10% of predicted, and worsening of symptoms or radiological finding, or worsening of respiratory symptoms and increase in radiological fibrosis. However, a couple of years back, Dr. Ganesh Rakku and et al. defined PPF in a slightly different way. According to them, the physiological evidence of disease progression is absolute decline in FVC more than 5 years, and they can cut short the duration to 1 year of follow-up, within 1 year of follow-up. And then plus you need to have the other radiological evidences. So it is different from the inbuilt trial. So which is ideal? So this study actually compared the various criteria for defining progressive pulmonary fibrosis. And when we look at the risk of death or lung transplantation, more than 10% relative FVC decline has the highest hazards ratio of 3.1. Although combinations and other criteria also are significant, but the highest hazards ratio is for more than or equal to 10% relative fall in FVC. So what is important is we need to put everything together, and we need not wait for 1 year. If you want follow-up in 3 to 6 months, there is progression without an evident alternative explanation, you have to call it as progression. And acute exacerbation also needs to be differentiated from progression of fibrosis. We need to consider an underlying diagnosis of PPF as well. So a fibrotic ILD constitutes a significant proportion of all ILDs. Among them, a minority of them will satisfy the criteria for PPF because they progress. So the underlying diagnosis can be idiopathic interstitial pneumonia, or it can be non-idiopathic, which can be related to connective tissue, hypersensitivity pneumonitis, or exposure-related or drug-induced ILD. So we looked at our data. This was compiled by Dr. Sai Vijayshri, one of our research doctors, and it was presented in the recent ERS conference. So we looked at our registry, and we found out 33 patients who satisfied the criteria of progressive pulmonary fibrosis according to the ATS criteria. And then we compared with 132 non-PPF patients which have a follow-up of similar duration of at least 1 year. And when we found out that the PPF patients have more symptomatic at diagnosis. They are more dyspneic, they have more cough at diagnosis. And among the spectrum of patients, and in our series, 20% of our ILD patients will fit into the criteria of PPF. And the highest percentage is with idiopathic interstitial pneumonia, followed by hypersensitive pneumonitis, and then it is followed by idiopathic IPAF as well as CTD-related ILD. And when we did the logistic regression analysis on predictors for PPF, we found clinical findings of clubbing and Velcro crackles as strongest predictors for progression, as well as those who belong to the category of idiopathic interstitial pneumonia. They are also at higher risk of fitting into the criteria of PPF. This is another study which looked at multiple other studies which try to find out the risk factors for progression, and then they found out that in those with fibrotic HP, those who have an antigen detection has a lesser risk of progression to fibrosis because you can institute avoidance measure. In rheumatoid arthritis ILD, those who have UIP picture or high anti-CCP antibody levels or more fibrotic scores are higher risk of progression. In those with systemic sclerosis, those with poorer lung function at baseline and more fibrosis are at higher risk of progression. As well as ball lymphocytosis, if it is not there, they are at higher risk of progression in HP. How do you monitor these patients? PFT, at least vital capacity, and DLCO every 3 to 4 months in the first year. and repeat HRCT scans as needed, directed by the clinical context and the lung function decline. There is no fixed criteria when you should repeat HRCT. But if you are following up the patient and you are planning to stop treatment because the patient is improved, it's better to have a baseline at that point of time. 6-minute walk test has a corroborative role in monitoring the progress. How do you treat these patients? Before you start treatment, an accurate initial ILD diagnosis should always be pursued, because that has an implication not only for prognosis but also whether you need to add immunosuppression or not. And you need to establish risk factors for progression. In which situation you can consider antifibrotic upfront, that is without evidence of progression, those with IPF. That is a well standard indication. If your diagnosis is IPF, you are going to start antifibrotics. You don't wait for evidence of progression. In the senescence trial with systemic sclerosis, there is some evidence to show that those who are on nintedanib plus mycophenolate, there is some benefit, although it has not become the standard practice all over. So in those with systemic sclerosis related ILD, maybe if their lung function is bad or there is evidence of significant fibrosis, you may need not start for evidence of progression. You can start upfront antifibrotics. Similarly for RA-related ILD with UIP pattern. Which antifibrotic to use? Nintedanib has the greatest body of evidence. But however, there is pirfenidone also has a greater increasing evidence that it is also effective. We need to consider the side effect profile, how many tablets patient has to take, and also nintedanib has a theoretical risk of aggravating bleeding as well as causing arterial thrombotic events. So we need to consider all these factors when you decide which antifibrotic to give. Should you consider continuing immunosuppression if you are planning to start on antifibrotics? Yes, you can continue immunosuppressions, especially if you are considering a patient who has an OP pattern or NSIP pattern, they have myositis-related ILD, younger age, or you have the non-pulmonary symptoms that flare up on reduction in steroid dose. And previously patient has responded well to steroids. In those patients, you may consider continuing some sort of immunosuppression along with antifibrotics. So the take-home message is, any ILD, a close follow-up is essential to pick up progression. So how will you follow up? Pulmonary function test every 3 to 4 months, at least in the first year. Initial diagnosis and tailored treatment is very important. And not every patient needs treatment with antifibrotics. Thank you very much.
Thank you, Dr. Bala, for that concise and crisp talk. Are there any questions? We have about 5 minutes for questions. If you don't ask, Dr. Bala will ask you questions. Have any of you faced problems with patients progressing on treatment? I think we shouldn't have given food. People seem to have slept off. Even the usual person asking questions is not asking. The second row. Yeah, is there any, okay, since nobody is asking questions, yeah, is there any word out on lung transplantation in these patients? Do they follow the usual inclusion criteria, or is there anything different in the guidelines? Since nobody is asking, I'm asking.
Vimi, I will request Vimi, he is our...
I know. Vimi was talking.
He has the greatest experience of transplant in this audience. He is from Yashoda Hospital. He is our student.
So ma'am, the PPFE, there is no specific change in the guidelines from INSSLT for transplant. So as with the other ILD, it stands with a progressive decline of FVC of decline of more than 10% of FVC and the DLCO with associated pulmonary hypertension and other things for referral and listing. Only concern is there is always a concern about in these patients when to consider about an ECMO or extracorporeal support. So there is always a debate because somebody who is progressing and we feel that these are the patients we can initiate early extracorporeal support. That is still debatable, but otherwise the guidelines on the PPFE for an ILD remains the same from the INSHLD.
So if the patient is slowly starting with lung function 70%, he is doing well, but slowly starting to reduce. So what is the tip off in which you say that, okay, I need to list or
one thing is we look at the extent of pulmonary hypertension. So any of them with the PPFE phenotype, other than the routine echo, once in a while we do the RHC to estimate the realistic pulmonary pressure. Second thing is that the extent of exacerbation in them in the last 1 year. Otherwise, other things are 6-minute walk distance that is worsening, etc. But main things are the other two. That is the extent of worsening pulmonary hypertension.
Pulmonary hypertension is a marker that you need to.
Yes, sir. Because when pulmonary hypertension with the PPFE becomes sick, it's not resuscitatable. You have to have an extracorporeal support upfront. So these are the subtype which worsens progressively where we are left with no option.
Okay. Anyone else? Okay.
Yeah.
Dr. Thomas.
Dr. John Matthew.
You said RA-ILD probably RA-UIP could start pirfenidone. Is it some database or you are extrapolating?
Extrapolated. So what about systemic sclerosis? I wanted to get your opinion. When do you consider upfront antifibrotics will be beneficial?
So most of the early systemic sclerosis don't because the fibrosis part is very less. But later on, late stage or people who come very late, diffuse disease sometimes do. But one of the problems with systemic sclerosis, they themselves have a lot of bowel symptoms because of the disease itself. And along with that, pirfenidone, it becomes a difficult. Nintedanib becomes a difficult thing. So how is your group of patients with the GI diarrhea with nintedanib?
Yeah, so it is very common. So some of them, when we start on nintedanib, we explain to them the diarrhea as one of the predominant symptoms, and if they are having problems with nintedanib, we shift over to pirfenidone, and many of them able to tolerate.
So diffuse systemic sclerosis per se, GI diarrhea and bowel symptoms are a major problem. So
well, mostly they tolerate. It's self-limiting. They mostly tolerate, and even arterial thrombosis in our patients is not very high. A few have had bleeding issues, but otherwise it's not a big problem. The pill burden is a big issue with pirfenidone, and they start reducing it on their own. If they have to take 6 tablets a day, 8 tablets a day, it's an issue. Again, photosensitivity is not a big problem in our patients with pirfenidone, because if you look at Western literature, they'll talk about broad-brimmed hats when you go out in the sunlight and all. Our patients don't have such kind of issues. So they do tolerate nintedanib quite well. They don't have too many
Sometimes
issues.
with dose reduction from 150 to 100 may help.
Helps. Earlier dose reduction was for cost, now it is for
Side effects.
And we have managed few patients with loperamide also.
Yes, that's right. Loperamide is also recommended to manage nintedanib-induced diarrhea. In fact, in the trials they have used loperamide as part of protocol if they have diarrhea.
Thank you, Dr.
Thank you.
Bal. So we'll move on to the third talk.